Welcome to Health or Consequences, the CommonWealth Magazine's podcast devoted to Massachusetts healthcare and public health policy issues. I'm Paul Haddis, one of the co-hosts from the Lown Institute, here with my colleague John McDonough from the T.H. Chan Harvard School of Public Health. And we're sitting down early in Thanksgiving week with somebody that we had on very early in our podcast history, but now is joining us as he winds up 12 years of being the CEO of the Massachusetts Blue Cross Plan, Andrew Dreyfus. Welcome, Andrew.
Hey, Paul and John. It's great to be here with you.
Thank you for joining us, Andrew. It's just a pleasure to be here with you. We see you. Our listeners don't, but that's okay. Just to get right into things, earlier this month at the Mass Health Policy Commission's annual cost trends hearing, you were viewed as sounding an alarm on healthcare affordability. What fuels your concern? What's the problem as you see it? And how bad is it right now, do you feel?
Yeah, John, it is a big problem, and I am very concerned. And so I think we all know, and I'm sure your podcast has covered, that hospitals and physician practices and other healthcare organizations delivering care are under a lot of pressure right now. They're facing high labor costs, labor shortages, supply chain issues, and we appreciate that and understand that. And we expect that hospitals and health systems will be asking us for kind of higher increases than they had in the past. But we're, on the other hand, also hearing from our customers, from employers and individual consumers who themselves are facing intense economic and financial pressures and who can't really bear increased cost of health insurance. In the past decade, John, we've probably averaged between 2 and 3% kind of unit costs or price increases from our hospitals and physicians. And by doing that, combining it with value-based payments, we've been able to, as a plan, and for the most part as a state, stay within the state benchmark, either when it was 3.6% or 3.1%. I think that's really at risk now. Hospitals, which used to negotiate with us with an eye towards that benchmark and to not exceeding it, have been very explicit with us that they think it's not relevant today. Many of them have been asking for increases that are 4 or 5 times the size of the benchmark. And of course, for your astute listeners, they'll know that the price of care usually only represents about half of the cost of care because there's a factor for the utilization and severity. And so it really puts us on a path that we've been before, and you've experienced before, where healthcare premiums will start to grow at double digits. Health employers, or just employers in Massachusetts, will find that unsustainable, and inevitably the government will intervene either by capping the rates of health insurance premiums or possibly with the Health Policy Commission taking a more aggressive role around the prices of providers.
Now, Andrew, you've been worried, I know, and sounded the alarm about on affordability, and particularly at this past cost trends hearings, but I know you've been raising that issue of concern now for a little bit of while. And one of the contributing factors I know you noted specifically at the 2021 hearings a year ago was market expansion related factors contributing to some of the challenge. And you at that time said that perhaps expansion ought to be a little bit more difficult for larger and more expensive healthcare providers. Are you still thinking that? And if so, how to best accomplish that?
Yeah. Paul, there's a very strong body of evidence now that's been collected over the last decade or more that suggests that when health systems or hospitals or provider organizations consolidate, it results in higher costs, higher prices, and not necessarily higher quality. And the evidence is pretty strong. I myself was pretty optimistic about that integration of healthcare organizations would actually improve both care coordination and quality. And there's some examples of that as well. But the stronger evidence is really about the price and cost increases. And we have already a very consolidated system in Massachusetts. I think about 80% of our payments go to 5 or 6 health systems in the state. And I think we should be very wary of any further consolidation without really strict oversight. So, for example, when the Beth Israel Leahy merger was approved, it was accompanied by some pretty strict conditions placed on it by the Attorney General about the rate at which costs or prices could be raised. So I think we need those kind of protections. I think today we still have, unfortunately, a somewhat disjointed regulatory structure in the state. We have responsibility given to the Department of Public Health on the Determination of Need program. We have the Health Policy Commission. We have the Division of Insurance, the Attorney General's office. I think we need some better coordination there, and whether it's strengthening the hand of the Health Policy Commission to look beyond the kind of narrow perspective they have now when hospitals or other providers consolidate, or whether we need closer coordination between the Attorney General's office and the Health Policy Commission and DPH. I think the status quo is unacceptable.
Can I ask you
and we need
corollary question to that, because you've been so far framing your response to us in terms of the acquisition kind of expansion mode, but what about the capital build out mode of either when you're expensive and either increasing your footprint with inpatient beds or ambulatory sites? Does the same worry apply in your mind?
Yeah, I think this raises the issue: could we have better coordination between the Department of Public Health DON process and the Health Policy Commission kind of market reviews? And I think we need a more holistic view. We need to understand the cost impact of some of these capital improvements and investments. And there's usually a price or cost consequence of these investments, and we have to think about the kind of downstream impact, even while recognizing that hospitals need to make investments. And we've learned through COVID around infection control and other reasons that some of these investments are important, but it's a matter of what kind of value are we ultimately delivering to the community.
Let me move you a little bit away from thinking about some of the bigger places to perhaps some of their those are hospitals that are a bit more challenged. The legislature recently passed a bill that gives about a total of $350 million out to Massachusetts hospitals because of the challenges that they're having financially. Did they direct the monies in the right way from your perspective, including to the most needy hospitals? And is this the best way to sort of help hospitals when they have these kinds of challenges?
Yeah, well, I think it was a smart use of public funds, and given a lot of the federal spending that came to Massachusetts in the response to COVID, I think helping especially vulnerable safety net organizations in Massachusetts is important. I'm not going to kind of debate or criticize the distribution method. It did seem like hospitals with a higher concentration of patients on public programs like Medicaid and Medicare got more of the funds. I would like to think that we, over time, would develop a probably more rigorous analysis of the needs of these hospitals. I don't think we do that in as careful a way. I am old enough to remember a time when we had a state health plan, and we actually analyzed health needs within geographies and within hospital systems within Massachusetts. We probably need that kind of program again. We have closed a lot of hospitals, so we do have to attend to those that are remaining. And it's not surprising that some of the hospitals, for example, in cities like Lawrence and Brockton and Holyoke and Springfield, often perform the worst in terms of kind of financial performance. And so we need to make sure we support them. On the other hand, one of the reasons that some of these hospitals are experiencing some difficulties is because the Medicaid program itself pays less than either the Medicare program or commercial payers. And so the state is kind of giving with one hand while it doesn't take away, but it pays less than it might with another. So I think we have to recognize that the state plays multiple roles here with these institutions. I occasionally get approached by a hospital that is in trouble in its community, and they're asking us for some special consideration. And what I often say is, let's go together to the Commonwealth and say, this is a needed hospital. How are we going to solve this problem, as opposed to these kind of one-off solutions?
So, Andrew, earlier this year, the Health Policy Commission recommended that health plans like Blue Cross and the other major carriers, as you capture savings, you should return it to premium payers. That may seem obvious to you or not. How do you respond to that recommendation, and were you surprised to see it?
Yeah, I wasn't that surprised. I think it actually intuitively makes sense. In some ways, we already have a mechanism today. Um, you might think of it as a kind of insurer efficiency index that was passed a decade ago. You probably had a role in writing those standards, John. And Massachusetts health plans, for example, have to spend, it was 90 cents, now it's 80 cents of every premium dollar in healthcare services. And if we don't, we have to automatically rebate the gap to our customers, which we did for the first time last year as a consequence of COVID. And so I'm not afraid of having tough requirements placed on us. And there may be other ways to do it. I still think that underlying drivers of cost in Massachusetts and nationally are the prices of both hospital and physician services and pharmaceutical costs. And we might want to talk about what kind of efficiency test do we want to put on those organizations in parallel with us. And ought we to have a mechanism that ensures that hospitals like health plans are spending the vast majority of their money on patient care.
Mm-hmm. So it's been about 2 years since Tufts Health Plan and Harvard Pilgrim Healthcare merged into Point 32 Health.
Yeah.
And the explicit rationale for it was that Blue Cross needed a stronger competitor.
Yeah.
So 2 years into it, have you seen changes in the marketplace noticeably from that merger? Has it changed anything?
Not particularly from that merger, John. I mean, first of all, I would just say we welcome competition, and both Tufts and Harvard were excellent plans, and I think Point 32 is an excellent plan, and I have great respect for Kane Hayes. They're still relatively new CEO, who's a colleague of mine. And it's still early in the process. I mean, I think we'll have to wait and see what kind of synergies they can create working together. I would say in terms of kind of larger system changes, I'm more focused on, for example, both provider consolidation, which I already touched on, the acquisition of large physician practices, for example, by Optum. And we really compete, while we compete with Point 32, we're really, the biggest competition we feel right now is in the national market with United, Optum, CVS, Aetna, and Cigna, Express Scripts, Evernorth, these three large companies that I think are 4, 5, and 13 on the Fortune 50 list, and compete with us for customers here. They have a lot of scale. They have a lot of different diverse businesses that they can cross-subsidize their health insurance, so they can actually lose money on medical insurance and make it up elsewhere. Like Point 32, we are principally a medical insurance carrier. We also have a large dental business and some other ancillary services. And so it's a little harder for us, also in a highly competitive environment, to earn the returns we need to earn to reinvest in our business and to stay competitive. So the market is changing. We're also just finally seeing, the entry of other big tech companies like Amazon and Google and Apple and Walmart and retail companies in the healthcare space. And so it's a very volatile, uncertain market. And obviously we believe that not-for-profit health plans like Blue Cross, like Point 32, like Fallon and others in our market are good for the community and have proven to be collaborative and have helped support some of the big health reforms we've managed here in Massachusetts. So I worry a little bit about losing that special quality that we have in Massachusetts. So we certainly in that sense want Point 32 to thrive and be a strong competitor and collaborator.
So back in, I think it was about 20 years ago or so at Blue Cross, there was a conscious decision to go for profit or to stay nonprofit. And they chose to stay nonprofit, and they set up the foundation of which you were the first executive director that played a central role in the Massachusetts 2006 health reform law. Is Blue Cross going to stay not for profit, do you believe? Are the pressures creating a situation where there needs to be a re-examination of that decision from a generation ago?
Yeah, I don't think we need to do. We do revisit it occasionally, within our board as we kind of refresh our strategy every 3 or 4 years. And every time we ask the question, John, we have the same answer, is that we believe that our community focus is actually an advantage for us, and that our brand in the community is known for its kind of commitment to the healthcare system and to our members and our customers. And we've actually been making some big investments in areas like mental health and health equity, and that I think we would not do with the same depth and commitment if we were, for example, a for-profit or a publicly traded company. And so I'm hoping that that continues to be the case, that our commitments to the community both serve us well and actually create some advantage for us competitively. We really believe in our not-for-profit mission. We are one of the, if not the only Blue Cross plan in the country that's legally chartered as a public charity, and we take pride in that.
Okay, so no one should lose any sleep worrying that they're going to wake up and see that Blue Cross wants to go for a profit.
They should not lose any sleep over that.
Well, Andrew, let me turn to the elections and a key result, which in our state includes a new governor, Maura Healey, starting the first week of January. Do you have any thoughts for her and her new administration about top healthcare priority issues that they ought to be thinking about?
Yeah, well, we've mentioned a few of them. First of all, I'm enthusiastic about Governor-elect Healey. She has been an attorney general who's listened very carefully to the healthcare community, has not been afraid to make tough decisions. We referenced a few earlier around healthcare when she did one of her first acts in office, and so she's a strong partner and a great leader. I think affordability is going to be one of the first issues she's going to have to face. We talked about it earlier. The pressure that hospitals and other healthcare organizations are facing in terms of labor costs are putting a lot of pressure on health plans like ours, and will result in higher premiums and higher underlying cost trends. I think COVID is not going away, and that any governor is going to have to pay a lot of attention to COVID. And I think we can't lose sight of that, even as we return to more kind of normal status, that we're just one difficult variant away from being in a really challenging situation. I think health equity is the other big issue I would raise. We're working very hard on this. There's a lot of momentum behind making big investments in health equity in Massachusetts. I'm sure this is an issue the governor-elect cares about a lot. Some of us, including both of you, have worked on health disparities and health equities for 20 or 30 years, but I think we would all acknowledge that we haven't really made a lot of progress. And this is, I think, the time to do it. We took a few steps. We did an audit of our own disparities and published our first health plan in the country to kind of publish our own health disparities, and then gave similar audits to the physician practices that we work with so they could see how they fare compared to some of their colleagues in the community. We then worked with the Institute of Healthcare Improvement and gave them a $25 million grant to help see changes in hospital and physician practices. And we hope literally within the next few weeks to announce that we have our first health system that is going to accept health equity measures as part of our value-based framework. So we're actually going to be paying for equity improvements, striving for the goal of zero disparities. So I think healthcare affordability, COVID, and health equity would probably be top of the list for the incoming governor. She has a few other issues outside of healthcare to worry about too.
Exciting evolution, and I guess John and I will look forward to seeing the details of that arrangement with the system. So you've given a pretty good laundry list for the state, but let's turn to what's going on nationally now, where we're going to have a Republican-controlled House, a very narrowly controlled Senate by the Democrats, President Biden having 2 more years. Do you expect anything much to happen in the healthcare area in these next 2 years out of Washington?
I don't, Paul. I think divided government will probably cause gridlock, especially on healthcare issues. We may see some small movement in issues like telehealth innovation, or we obviously have the recently passed pharmaceutical pricing reforms, and it'll be interesting to see to what extent the House tries to challenge that. I think we'll see some investigations on the House side, although with such a narrow majority, I think they may be limited in how far they can go on that. One interesting issue that I've been reflecting on is what wasn't in debate during the recent election, and that was the Affordable Care Act. And so every previous election has been a big issue. It's, to me, a kind of testimony to the lasting impact of that law. John, you worked on a lot, both at the state level and at the federal level. And so I'm pleased to see that. It's a reminder that reforms take a long time to really take root. There'll be some issues as we come out of the public health emergency. There'll be some issues about a lot of people who have been able to stay on Medicaid or subsidized insurance, and some risk of many of them falling off in the coming year as that public health emergency is wrapped up. But I don't actually think the federal government is going to be kind of locus of a lot of healthcare innovation reform, which is why our earlier conversation about trying to kind of strengthen the Massachusetts regulatory framework around affordability, I think is really important. And we've seen, and John, you've written about this, that the locus of healthcare innovation at the government level kind of goes back and forth from the state and federal government almost by the decade. And I think we're going to be back in a state decade. And I've been watching, as you probably have, some initiatives in places like Colorado and Oregon and Washington of kind of public options and things like that. So it's going to be an interesting time to follow state health reform.
So I'd like to ask you just a little bit about the national health insurance industry as one of the few major nonprofits in the industry right now. You play an important role, or you've played an important role in the National Blue Cross Blue Shield Association and in America's Health Insurance Plans, which is the major lobbying organization. Over the decades, the national plans have become larger and larger and more consolidated and buying up competitors, where we're seeing, for example, in the Medicare Advantage market, a concentration among the major players. Most of them, except for Kaiser, are for-profit. Do you think the U.S. right now is too overly dominated by the large players in the insurance industry? And we know the Biden administration has been taking a different attitude on antitrust. And I'm just wondering your views on what's going on, what's happening on the national scene.
Yeah, you're absolutely right, John, that there has been a lot of consolidation on the health insurance side, as there has on the health system or health delivery side. And there actually has not been a lot of strong antitrust enforcement over the last decade, although you're right that there's a new interest in it, maybe a little late in the health insurance side, because we have three such large national plans. And as I mentioned earlier, they're very diversified, that own assets and pharmacy benefit management and care delivery. And so I think we're going to have to watch that very carefully. There is still a strong presence of not-for-profit plans, especially not-for-profit blue plans in the country. We still have the largest collective membership in the nation, every zip code, every neighborhood in the country, and mostly not-for-profit. There are there's one group of publicly traded plans within the blue system. I think that we have to continue to assert the not-for-profit voice and mission here. I think it is different. I think it matters. And I know that we will continue to do that here in Massachusetts.
If we're not careful, could we in Massachusetts wake up 5 or 10 years from now and see our health insurance market transformed into a for-profit space largely? Is that a risk or possibility?
I think it's always a risk, and I do worry about that. And so that is something that kind of keeps me up at night, so to speak, that these plans will get, these publicly traded plans will be so big and so influential and own so many assets, it'll be hard. I've had to get to know two words that I don't yet accept in Scrabble. One is frenemy and the other is co-opetition. And so, in some ways, because let's say in the case of United owns Optum, which owns Atrius Health and the Reliant Health in the Central Mass area, we need to work with them, and we have a positive relationship with them. We work with CVS both in a retail way and starting in January as our pharmacy benefit manager. And so I think we're going to probably have a mixed system and work together, but it's something we're going to have to monitor. And I think it's something, again, the state should keep an eye on and think about whether there are opportunities to actually protect and ensure that not-for-profit health plans thrive in the state.
Andrew, as we begin to wrap up, and I could have started our discussion today with you, but decided maybe to do it here, which is to briefly comment on not only the 12 years as CEO of the plan and working on equity issues, as you just mentioned, or the alternative quality contract and many other accomplishments, or before that at the foundation and the roadmap to coverage, which was, instrumental in leading us to what ultimately became known to probably our listeners as Romney Care, and then, work at the Mass Hospital Association and in government for the Dukakis administration is a rich experience that you're leaving your current position from. And so finally, any words from all of that perspective to share with Sarah Iselin, your successor, as well as maybe sharing a little bit with our listeners about what your professional engagement efforts are likely to look like next, if you would.
Yeah, well, Sarah Iselin is one of the best, smartest, most strategic people I've ever worked with. So I think she probably doesn't need much advice from me. And I think she's going to be a superb leader, both adding, and strengthening the work we're doing in areas like health equity and mental health, but I'm sure bringing her own views and ideas and innovative mind to the company and to the healthcare community in Massachusetts. I think we're lucky to have her back. In terms of my own plans, I'm stepping down as CEO of Blue Cross, but I actually am not retiring from the healthcare. And I'm going to stay focused on this mission of trying to make healthcare better, both make it higher quality, more equitable, and more affordable. I plan to do that through advising some both young and mature companies, doing some teaching. I'll be a fellow at the Harvard School of Public Health in the spring semester. I just joined the board of the Joint Commission that regulates and oversees hospital quality and safety, which connects me back to some earlier work in my career on quality and safety. I started my career as a journalist. You didn't mention that, Paul, but I plan to do some writing. I've tried to write while I've been in this job. I think I'll have an even freer hand now. And so I hope to kind of contribute to the dialogue and debate about how we continue to kind of push the healthcare system forward in a collaborative way and take some of these lessons that we've learned in Massachusetts about collaboration and cooperation and trying to kind of get out of our healthcare silos and act not in our individual company's interest, but kind of in the community interest. So I plan to do that. I look forward to kind of mentoring. I've been doing some mentoring of some next generation leaders, and that's a fun way to kind of pass on some perspective and experience.
So we are regrettably, Andrew, out of time. I just want to say personally and professionally, congratulations on 4 amazing decades of service from so many different points of view in Massachusetts healthcare and health policy. And congratulations. It's been a really amazing ride to watch, and we're glad that you're still going to be active and engaged. So much appreciation for joining us and for everything that you've done.
Thank you so much, John.
That wraps it up. We will be back in December, and we're having a kind of a goodbye tour with these additions. We'll be welcoming in December Health and Human Service Secretary Mary Lou Sutters from the Commonwealth of Massachusetts will be stepping down after 8 years in that role in December. So we hope you can join us on that. And for my colleague, Paul Haddis, and thanks again to Andrew Dreyfus. Thanks everybody for joining us.